She is 43. She goes to her general physician for fatigue, gets told it's anemia. Iron tablets prescribed. 3 months later, she goes back, still exhausted, not sleeping. Her periods have become unpredictable. She has gained weight around her middle despite eating the same way she has for 20 years. She is short tempered in a way she doesn't recognize in herself, and she apologizes for it constantly. Her doctor says stress. Her husband says she has become irritable. She believes both of them. Her labs come back. FSH is borderline. She is told she is not yet in menopause. She is sent home. She is actually in perimenopause. She will not get that word for another 2 years. This is not one patient. This is the majority of women I see in their early 40s in my clinic. Hi, I am Dr. Sunana. I am a gynecologist with over 12 years of clinical experience. And today I want to talk to you about the symptoms that arrive years before any doctor mentions perimenopause. The ones you have been explaining away, pushing through, or never saying out loud at all. Perimenopause is not a moment, it is a transition. The years of hormonal fluctuation that happen before menopause begins. It can start in the late 30s. It typically lasts 4 to 10 years. And menopause itself is not a phase, it is one specific point in time. 12 consecutive months without a period. Most women think perimenopause is about hot flashes and missed periods. No, it is not. Or rather, those are two symptoms on a list of many, and they are often not the first ones to appear.
Here is the thing about estrogen in perimenopause that almost nobody explains clearly. Estrogen does not simply decline, it swings. Some months it spikes higher than normal. Some months it crashes. There is no predictable pattern. This is why one week feels manageable and the next feels unbearable. This is why you have a good month and think it's over. And then the symptoms return worse than before. Your nervous system cannot regulate what it cannot anticipate. When estrogen is erratic, your brain's chemistry is erratic. The psychological distress you feel is not separate from the hormonal shift. It is the hormonal shift. These are the same thing. This unpredictability, the complete absence of pattern, is itself a clinical clue. And it is the reason so many women in perimenopause believe something is wrong with their mind rather than their hormones. Let's talk about the symptoms. Symptom 1. This is a symptom she monitors in private and tells nobody about. Her cycle changes. Longer, shorter, heavier, lighter, sometimes skipped. She attributes it to stress, weight fluctuation, travel, etc. She waits for it to regulate itself. What is actually happening? Ovulation is becoming irregular. When ovulation is inconsistent, progesterone, which is produced after ovulation, drops first. Estrogen fluctuation begins. The cycle changes are the first visible sign of a hormonal shift that has already been underway for months. Irregular periods in a woman over 38 with no other explanation is perimenopause until proven otherwise. Every month she spends waiting and watching is a month of unmanaged symptoms. Symptom 2. Sleep disruption. She tells herself it's her phone, her schedule, anxiety, or simply getting older. She is waking at 3 am with her heart racing. She cannot fall back to sleep. She is exhausted by 2 pm and wired by 11 pm. What is happening? Estrogen affects thermoregulation. It also affects serotonin pathways, which regulate not just mood but sleep initiation and sleep maintenance. When estrogen fluctuates, sleep architecture fragments. The night sweats she notices are vasomotor instability. The racing heart she calls anxiety is the same mechanism. Sleep deprivation then amplifies every other symptom on this list. The mood swings get worse, the brain fog gets worse, the fatigue becomes severe. She thinks she has multiple problems. She has one underlying hormonal shift creating a cascade. Symptom 3, mood swings and rage. This is the symptom she feels most ashamed of. She snaps at her children, she is short with her husband, she cries without knowing why, and then she apologizes. Repeatedly, she tells herself she has become difficult, that something is wrong with her character. What is happening? Estrogen directly modulates serotonin and dopamine, the neurotransmitters that regulate emotional response and stability. When estrogen swings erratically, neurotransmitter levels swing with it. The brain's emotional buffering system is destabilized. She has not become a different person. The same brain that produced decades of patience and composure is now operating without its primary regulatory hormone. This is neurological, not a character flaw, not a reflection of her relationships or her choices or her mental strength. The shame of the rage is often worse than the rage itself, and the shame keeps her from naming it to a doctor. Symptom 4, fatigue. She is tired in a way that sleep does not fix. On the days she does sleep, she pushes through, she adds supplements, she tells herself she needs to exercise more, manage her schedule better, stop complaining. What is happening? Disrupted sleep plus hormonal fluctuation plus frequently an overlapping subclinical thyroid shift, all compounding simultaneously. Estrogen also affects mitochondrial function, that is, the cellular energy production. The fatigue is not motivational, it is physiological. And then there is this: Indian women in their 40s are not culturally permitted to be tired. She performs functioning. She shows up. She manages. She says she is fine. The fatigue becomes invisible because she hides it so well from her family and from her doctor. 5. Weight gain. She is eating the same way she has eaten for 20 years. The weight is not moving, or it is increasing, specifically around her abdomen, in a way she has never experienced before. She concludes no discipline, getting older, her own fault. What is happening? Estrogen decline shifts fat distribution centrally. This is not a diet problem. Cortisol sensitivity also increases during perimenopause. Chronic stress now stores fat differently than it did at 32. Insulin resistance can begin emerging even in women who have never had blood sugar issues. She eats less, exercises more, gets the same result, concludes she has no willpower. She has a changed hormonal environment that requires different interventions, not harder effort on the same ones that used to work. Symptom 6, low libido and vaginal dryness. This is the symptom that goes unspoken the longest. She will not bring it to a clinic unless directly asked. She interprets it as loss of femininity, as a marital problem, as something she should manage privately. What is happening? Estrogen decline causes vaginal atrophy. The tissue becomes thinner, drier, less elastic. Intercourse becomes uncomfortable or painful. Testosterone, which also declines in perimenopause, affects desire, energy, and sense of self. This is the most treatable symptom on this list. Local estrogen therapy is safe, effective, and does not carry the systemic risks associated with oral hormonal therapy. But it requires her to say it out loud first to a doctor, which she will not do unless someone tells her it is a medical symptom, not a personal feeling. I am telling you now, it is a medical symptom. 7. Hot flashes. This is the one she mentions, and ironically, it is the one most likely to be dismissed because that age is culturally accepted as something that just happens, not something that gets treated. What is happening? Estrogen fluctuation disrupts the hypothalamus, the brain's thermostat. Vasomotor instability follows. Sudden heat, flushing, sweating, then chills. This is not cosmetic discomfort. Frequent vasomotor symptoms correlate with cardiovascular risk and significantly worsen sleep disruption and mood dysregulation. Hot flashes are a clinical signal, not a rite of passage. So she finally goes to a gynecologist. FSH is tested. The result comes back normal or borderline. She is told she is not in menopause yet. She goes home. Here is what that actually means clinically. FSH in perimenopause fluctuates cycle to cycle, sometimes week to week. A single FSH on a single day tells you one data point from one moment in a years-long hormonal transition. A normal FSH does not rule out perimenopause. It rules out one reading on one day. Perimenopause is a clinical diagnosis. That means symptoms plus history, not a number on a lab report. If the symptoms fit, irregular cycles, vasomotor symptoms, sleep disruption, mood changes, the diagnosis stands regardless of what FSH says on any given day. The women who get sent home after a normal FSH are frequently the women who needed the most support because they are in the perimenopause with normal labs.
If you recognized yourself in this video, the fatigue you explained as stress, the sleep you stopped expecting, the rage you apologized for, the weight you blamed on discipline, that recognition is enough to start with. You were not falling apart. Your body was changing, and nobody gave you the language for it. Next Tuesday, we cover the management side. What actually helps? What the evidence says about hormone therapy in Indian women specifically, and what lifestyle interventions are physiological interventions, not just general advice. If this video was useful, share it with a woman in her 40s who is just pushing through. She may not know she needs it yet. Your body has a logic. This channel exists to give you the language for it.